So let's start. Today's webinar is about smart preparation for Plab, both Plab 1 and Plab 2. Before discussing the preparation, we should be aware of the objective of GMC for setting this exam. The main purpose behind this is all international medical graduates who want to come to the UK should be able enough to follow their criteria. This is language, this is basic medical and clinical knowledge and skills, as well as communication skills according to their ethical and cultural values system. I hope I'm making sense. So I know we have participants for Plab 1, for Plab 2. So we'll talk about both exams, that how can we prepare smartly. For Plab 1, I'll remind all the candidates that don't underestimate the exam. Apparently, some people say it's quite easy, it's straight, or it's not much complicated. However, an exam is an exam. Before going for exam, before booking your exam, assess yourself. How much time do you need to prepare this exam? There should be advanced planning with set realistic goals. How much time do you get for your preparation every day? And how many days in a week? And how can you prepare? Are you a working doctor? Are you staying at home mom? Or you're a fresh graduate or an experienced doctor? It all depends upon your personal situations. But make it clear that this exam is, though comparatively straight as compared to post-graduation exams, but it addresses certain situations in which there can be application of medical skills, clinical knowledge, evidence-based knowledge, current guidelines, assessment and knowledge, or ethical value system. And then comes what should be the way to prepare. In this way, we are blessed that GMC provides sample MCQs on GMC's website. These are pretty good 20 to 30 questions, which can give you an idea what kind of knowledge is being expected from a Plab 1 candidate. And then there is GMC Plab Blueprint, which covers all the cases like topics which a junior doctor should know. For example, GMC expects from a junior doctor to know that what is headache, which case can be a medical emergency, when there is an acute intervention needed, when we can reassure patient, when we need to give a symptomatic medication to a patient presenting with headache, or when there can be a background condition going on. I hope I'm clear so far. So these two resources, the GMC sample MCQs and GMC Plab Blueprint, they give better idea that how a candidate should start their preparation. And on this criterion, you can find a question bank suitable for your preparation. Question bank is the base and foundation of a Plab 1 candidate's preparation. When you go through a question bank, start with a SMART goal, putting a timer so that you prepare your questions against a time window. For example, in exam, you have 180 questions to be attempted in 180 minutes. On an average, 1 question per minute. If you prepare on this speed, it will be good. To start with, you can take more time. However, eventually you should end up doing more than 1 question in a minute. Later on, make foundation of your knowledge, because with question bank explanation, that explanation is related to the scenario. Sometimes it doesn't cover the whole topic. There are certain gaps. To cover those gaps or to complete the topic, just give a look in your book or any reference material. You can use flashcards and notes for smart and quick revision in the last days. Mocks are really helpful for Plab 1 preparation as well. It all depends upon you. You like to study on your own, or you like group discussions, or you like combined studies. But whatever you like, try to make a plan and stick to your plan. Plab 1 assesses applied knowledge. Sometimes it's not all theoretical. It's related with evidence-based medicine, and sometimes they ask according to their guidelines. Train your mind to assess the question, like which words are being used. For example, mostly, commonly, most probably, rarely. These words change the whole scenario of the question. Train your mind with confidence. Whenever you do a whenever you get a correct answer, use this correct answer to build your confidence. And if there is a mistake, just find out the cause of that mistake. That why couldn't you think that way? And try to avoid that mistake again. As human beings, we tend to repeat our mistakes. So it's better if you find a mistake, just focus upon it, that what was the wrong thing going on, and then clear that concept. Basically, practicing question banks, keeping in mind GMC sample questions and blueprint, you will be well prepared for Plab 1. If you have any questions, drop in chat box and I'll answer later. Now coming towards Plab 2. Plab 2 is the practical part of Plab exam. It has 16 working stations, 2 rest stations, in total 18 nowadays. They give 8 minutes to do every station to complete our task, and 90 seconds or 1.5 minutes outside the cubicle to move between the cubicles, to read the question and to relax. This whole exercise takes almost 3 hours. You are supposed to reach the center around an hour before. There is some briefing before the exam, and they check your identity and keep you awaiting in a waiting area. So from entering to the GMC building to leaving, it makes around 4.5 hours. So we should, as Plab candidates, Plab 2 candidates, you should be ready for these 4.5 hours of a little bit stress, anxiety, and a roller coaster ride of 16 stations. Okay. After briefing, when you reach in front of your cubicle, you find the question there. At that point, you need to be alert. Read the question. It will tell you, where are you standing? Like, is it a GP practice? Is it a hospital? Is it emergency department of the hospital or any other department? This setting affects your management plan. There are certain things that you can do in GP practice, but not in hospital. All the same, many things which can be done in the hospital are not possible in a GP setting. So keep this setting in your mind before starting your station. Then you will be given details of your patient, that is name of the patient, age, usually presenting complaint or any concern with which they have come. Usually while standing outside the cubicle, you come to know about the station, that what kind of scenario is being presented. And mostly it is evident by the task given to you. Task can be according to your question: to manage the patient, to negotiate with the patient, to reassure patient if it is, or for acute treatment, anything. While standing outside the cubicle, you can well assess what kind of task there is. And this gives you pretty much idea about type of station. But please don't assume things. Don't go inside the cubicle with a set diagnosis in your mind. While standing outside the cubicle, you can think over differential diagnosis. You can think over red flags related to that condition. You can think over certain management points in your mind, but don't go inside the cubicle with something fixed in your mind that I have identified this case and this was related to that. Okay, this can be that thing. Don't assume things, don't invent things. Just go with the flow of the patient and then information will come up. Plab 2 is a different way of assessment. There is qualitative assessment, quantitative assessment, and subjective assessment. In qualitative assessment, they don't give you marks, but there is either yes or no statement. There are 10 qualitative criteria in every case, in every station. So there are total 160 points to get or collect, which are not in terms of marks, but in terms of good or bad, yes or no, whatever they said. In quantitative criteria, every station carries 12 marks, equally divided into 3 categories. 4 marks for data gathering, 4 marks for management, and 4 marks for interpersonal skills. And being subjective, a candidate is supposed to pass certain number of stations, that is 10 out of 16 is minimum, to score certain marks, that is the more than minimum for that day. So it depends how well you performed on your exam day. Also, it depends how well other people performed on that day. If among 16 candidates, all are very competent, passing score will rise, and there may be a chances of being eliminated of good candidates as well. And also it depends upon role player, how cooperative and understandable role player was, how was examiner, how did he found your performance. So we are supposed to coordinate each and everything during our practice sessions. These things will be clarified in our further discussion. So in qualitative criteria, I talked about 10 phenomena. First of all, there is consultation. And according to GMC, they look for a well-organized, structured consultation in which there is no random jumping from one question to the other. There is no jumping from data gathering to management and back to data gathering. Your consultation should be in a flow. While preparing, you can structure your consultation according to a group of cases. For example, there's a different structure working for gynecology, a different structure working for pediatrics, psychiatry, medicine, ethical, counseling stations. So stay within that structure, stay focused. Focused means there are certain things which are quite important in one situation, but are not important in another situation. So just think about your question, think about that statement, and filter which things you need to ask and which things you need to omit. Relevant. Consultation should be relevant to the presentation of scenario. Relevant things must not be omitted. You're supposed to pick all the red flags, all the concerns of the patient, and every psychosocial element of the patient relevant to his situation. Coming towards diagnosis, it's significant in the cases of medicine, peds, gynecology, psychiatry, ENT, Here, you should have some differential diagnosis in mind and rule out those diagnoses during your consultation to present the examiner that you are thinking on that line, so that they know you are just not jumping to the diagnosis, you are filtering other differential diagnosis to reach your provisional diagnosis. In some cases, they give you certain blood test reports which are evident of a confirmed diagnosis. In that case, you can use a confirmed diagnosis. And if not, if still investigations are to be done, in that case, give a provisional diagnosis. The diagnosis should be working, logical, and correct. Because if you don't proceed towards correct diagnosis, whole of your consultation will be moving on wrong side. Because if you don't work upon a right diagnosis, your management, whole of your management will be affected. So you may get marks on basis of interpersonal skills, a few on data gathering, but because of wrong diagnosis, your management will be badly affected. And one more point, when reaching to diagnosis, it's important to explain the diagnosis to the patient in simple language. There are few cases when they ask the candidate to work upon the case and tell the diagnosis to the examiner. In that case, we are not supposed to tell the diagnosis to the patient, but we will talk to the examiner about diagnosis and management. Examination. Examination is part of qualitative criteria of every station. The good thing is we are not supposed to perform examination in each of the 16 stations, but we are supposed to mention it verbally. There are certain cases which are known as combined stations in which we perform examination. In those cases, we are supposed, as candidates, we are supposed to mention appropriate exposure, take proper informed consent from the patient. Our technique should be correct. And if we need to use certain instruments, we should be fluent and skillful in using those instruments. And after examination, there are findings. Again, when we verbally mention examination to our patient, we are provided examination findings on a nice clipboard, on a piece of paper, printed. In that case, it's a good part to score IPS marks, interpersonal skill marks. Get up to receive those findings get up from your chair, rather patient gets up and provide those findings to you. And say thanks to the patient for handing over you these findings. Then go through those findings and inform the patient about those findings in an empathetic way. It carries value. If you don't inform your patient about the findings, candidates are being marked down. Then there are issues, and usually issues make the core of the station. Issues can be in the background, apparent, associated with physical problem, or any way. To find out the issues of the situation or station, we have certain tools. The best tool is ICE, I-C-E, where I stands for idea, that about that certain condition, what's going on in patient's mind, what he's thinking, that what could be the reason of that particular condition, or why is he experiencing. And usually when we explore idea of the patient, usually we get some clue. If we use that clue, we can save our time. Then concerns. Mark this word concerns in your mind. If you don't address concerns of the patient, of the role play, it's difficult to make that station. And if you address the concerns of the patient and miss certain other things, it's quite possible to make that station with good marks. Concerns are really that important. There can be anything related to patient's physical problems, patient's social life. There can be some safeguarding issues. There can be certain issues related to minors, young children below the age of 16. There can be certain issues related to elderly. There can be cases of domestic abuse. So anything which is concerning patient is vital for us to explore and to bring it up in the management. And then expectation, that what's patient hoping while coming to the consultation. Sometimes it happens when the candidate tells a role play, okay, I'm going to admit you, and patient says, oh, I was not hoping this. I was not expecting it, doctor. So in this way, and then we are supposed to address these expectations, either by convincing the patient or bringing something up according to their expectations, if it is in our hands. Psychosocial part of data gathering. It's significant, it's important, and many times hidden agenda is lying here. For example, a role play who is diabetic and is unable to control his diabetes by preparing his meals or taking care of his blood sugar level or going out for walk or exercise. When he is explored, he tells, I have an old mom at home and I am supposed to take care of her. So I don't get time to take care of myself. So this thing changes the whole management plan. Never forget to ask about patients' psychological aspects of health and social life. Who is living with the patient? Any stresses at home? Any stresses at workplace? What kind of job the patient is doing? And is he experiencing any symptoms of depression? These all things are supposed to be covered in this area. And then there are certain ethical issues. Ethical, it can include ethical, cultural, religious. For example, in an emergency case, if patients refuses blood transfusion because of their religious beliefs, or in a case of minor, where we are concerned about her safeguarding, or there can be a case of domestic violence, where we may need to involve police or other security agencies. So issues is the core of the station most of the time. Then comes language. They have assessed candidates' language skills before Plab 1 in OET or IELTS, but they want their doctor to be clear in simple in language. They don't want Shakespearean English, but they want to be the language very simple. which patient can understand easily. Language should be non-judgmental and non-authoritative. Should, must, don't, these should be avoided. The best idea is to use drawing room manners while using certain aspects of language. Give personal space to the patient, be decent, be comfortable, and be quite understandable for the patient. In this way, if you have to repeat something for the patient, don't say, I have told you earlier. No, just explain it again. All the same, if patient is offended by any of your question, be polite, be gentle, and excuse from the patient. This really does matter. And now comes listening and GMC feedback about GMC's do's and don'ts file that contains maximum material on listening. This is an area to score high in IPS as well as to score overall high and make most of the stations. When the patient is talking, please listen to them actively. Respond to them by your body language as well as by verbal response. You can nod your head, you can use your hands to presenting that you are listening to them or you are with them, and you can say and encourage them to speak. Don't interrupt your patient. It is in your favor. When patient is saying, they are not saying anything other than advice to them. So whatever they say, that is for the candidate's favor. And when patient is saying something to you, show appropriate concern. Don't fake empathy, but be concerned. If it is something pleasant, acknowledge it, comment it, appreciate it, encourage it. And if it is something unpleasant or patient should not do that, just politely talk about it. If you don't understand what the patient said or you couldn't get what is in his mind, just ask him to repeat. Just clarify the thing. It's rather better than assuming the thing. So listening is another very important area of qualitative gain. In the management, this is the part where our candidate, our doctor will not talk much. This is the area for the patient to be involved at each and every step of management. And whatever data you gathered in first 5 minutes, bring all those things in this management. For example, if patient was having some concerns, now present to him the solution of those concerns. If patient was having some issues, bring up some solution for those issues. While taking any big step during management like admission, get consent from the patient. Whatever you are going to do in terms of treatment, explain to the patient. If you're going to refer the patient to some consultant, then explain the patient that why this referral is needed and what will be done there. What will consultant do? And in fact, we are supposed to give a management plan. If it is an acute condition, then until that condition is being treated. If it is a chronic condition, we will give a management plan with follow-up. If it is a lifelong condition, we will give a rough sketch of that lifelong management. During management, chunk and check. Give a small chunk of information to the patient and check, do they understand? And the best way to use to quickly wrap up management portion is using resources. These can be leaflets, which are quite often available for every other condition. These can be internet sources, certain websites. Don't refer your patient to Google their condition, but you can offer them a known website, an approved website by GMC like NHS or certain other websites which are affiliated with GMC. Never ever miss safety netting. Safety netting is actually like protecting the patient. When we safety net the patient, we protect our patient from any negative thing happening. And then comes a criterion of rapport building. Rapport means empathy, harmony, and it can be done during effective introduction. When you enter the room, enter with a smiling face, unless the situation is of breaking bad news or angry patient. Rest all the cases, enter the room with a smile on your face, have an eye contact, pay greetings, and try to use patient's name, which is quite helpful in rapport building. Rapport building goes throughout the station. However, the best time to build a rapport is the first 30 seconds in which you introduce yourself, you confirm patient's identity. Here, you are supposed to smile and eye contact. And when you sit, take care of patient's personal space. Don't lean forward much. Don't sit backwards much. And by your body language, convey a message of harmony. And the last thing which candidates usually find hard and difficult, that is time management. There is 8 minutes window for every scenario. But I can assure you that these 8 minutes are quite enough, because stations are designed in a way that a candidate can comfortably complete those stations within 8 minutes. The key is you should know what you need to ask, and for that purpose, practice will help you. Now comes the question that how to practice. For this, again, identify yourself, what kind of person you are. If you like practicing with one person, it's fine. If you like practicing in a group and with a group discussion, that is perfectly fine. But practice, keep on practicing. In Plab 2, the ratio of reading and practicing should be 9:1. Reading time doesn't matter much, but practicing time does matter a lot. During the station, don't rush, don't panic, don't give an impression that, oh, I'm going out of my time, give me information quickly, and then I need to wrap up. No, just go with the flow of the patient, because patients are trained in such a way that they will be going through the station according to their guideline. Learn about prioritizing things, what should be done and what should not be. Don't waste your time in asking irrelevant things. GMC is quite particular about all these things. On GMC do's and don'ts, we find they say the interaction should be real. There must not be stock phrases. And a doctor should behave like a real doctor. Don't offer confidentiality when it is not needed. Don't go for consent when it is not needed. Don't make the patient feel offended. And be clear on your task. Whatever you are being asked, do that thing. For example, GMC says, if you are asked to examine abdomen, it means examine abdomen, no need to go for general physical examination. GMC doesn't confuse because they want to spare your time and to be consumed appropriately. But when we go away from our task, then we may waste our time. So time management is key. The best way is practicing a lot, practicing and then getting feedback. And whenever you get feedback or give feedback to your study partner, discuss all these 10 qualitative criteria. Because to go through these criteria will make your exam easy. And then coming towards quantitative criteria, these include data gathering, which is major part of your consultation. Roughly, if you divide your time 5:3, 5 minutes for data gathering and 3 minutes for management, it will be suitable as compared to dividing it 6 and 2, because in that way, at the end, you might be rushing. Data gathering should be organized, structured, focused, and relevant. Never ever miss red flags. Red flags means a condition with which if you send the patient back home, they may suffer some serious condition. For example, we cannot miss MI or pulmonary embolism in a patient of chest pain. If a patient presents with weakness, we cannot miss TIA or stroke. So identify red flags of every symptom and always rule out these red flags. Never miss ICE, idea, concerns, expectation of patient, and you can add one more E, that is effect of that symptom or condition on patient's life. And this addresses 5 areas which will save your time: patient's routine, patient's work, patient's sleep, and mood related to depression, and their family life. If any symptom is affecting any of these areas, we are supposed to focus more upon those conditions. Psychosocial and examination and in examination. So all these things are included in data gathering. It should be in a flow. First of all, history of presenting illness after introduction with open-ended questions. Then ruling out certain differential diagnosis, keeping red flags on top. Then exploring patient's past medical history, patient's psychosocial life. And in social life, we can filter certain things. We are supposed to ask smoking in every case, but diet and exercise can be omitted in many cases. And then exploring ICE. This should be the flow of your data gathering, and then coming towards examination. Never miss examination. It is actually verbalizing examination. So give a sentence and then you will get findings, and never miss to present findings to the patient. Then comes management. There are many aspects of management, but the key to management is address the concerns of the patient. Even if a candidate starts managing the patient by addressing their concerns and they miss some things in the management, actual management, either something symptomatic or specific, they can make the station. Management includes explaining diagnosis to the patient in simple, clear, crisp language. Always effectively use resources, because many things we are not able to talk during those 2 to 3 minutes window. We can provide resources to the patient so that they can find appropriate information. Safety netting is key because it will protect patient from deterioration. Don't forget to involve the patient at every step of management, and never forget to get consent for admission, except a case of psychosis when we are or safeguarding, when we are supposed to admit the patient against their will. As interpersonal skill, these carry 4 marks. So you can build good interpersonal skills by building good rapport, using the patient's name, saying thanks whenever they give you certain piece of information. For example, when they hand over findings to you, whenever they tell you certain information about their personal life, and smiling, building a good eye contact, using name of the patient at 2 to 3 times, pay thanks to the patient using nice words like please. Don't forget to signpost whenever talking about anything sensitive, for example, sexual health of the patient, whenever needed, and reassure the patient. And whenever needed, empathize with the patient. But avoid fake empathy and false reassurance. Now, any questions?
Hello?
Yeah?
Ma'am, we have to ask for ideas, concerns, and expectations, what they call ICE, right?
Yeah.
So where exactly you ask this, after data gathering or in between data gathering? Is there a structure for that? Like you should not be asking ICE in the first instance, it should be only after once you finish the Maftosa. Is there anything like that?
Yeah, it depends upon scenario to scenario. It can be variable. However, I find it appropriate at the end of data gathering, where we ask about psychosocial health of the patient. At that point, when we ask, is there any stresses, anything which is particularly bothering you, you're not needed to ask specifically with the name of concerns or ideas. You can use your word, but we need to look inside the patient, in the mind and in their life. So I personally prefer to ask at the end of psychosocial history. I used to ask about what are they thinking about, what's going on, and what is bothering them.
Okay, okay.
And for
Thank you, ma'am.
expectations,
One more
at
question.
the end of the session, if you get time, good time to wrap up, at the end you can ask, so is there anything else I can do for you today? That is the nice time.
Oh, okay. Thanks a lot, madam. One more question regarding the same. Can we, is it like, won't it be very awkward if we ask like the patient what ideas you have got regarding the disease? Like
Yeah, for
consensus
example,
expectation is very justifiable.
Yeah, as sometimes, for example, patient says, doctor, I think I pulled that thing or I picked that weight. And since then I'm having that pain, maybe this can be the reason. Sometimes we tend to forget specify something. So in that case, patient can give us a clue, but you are right, idea can be omitted in simple straight case.
Oh, okay. Thanks a lot, ma'am.
Pleasure.
Okay, can I ask again? Like nobody's asking, so.
Yeah, sure.
In non-accident injury cases, we have to explain regarding the social service safeguarding, right?
Yeah.
So how will you explain that in a good way to, daughter of a patient or son of some elderly guy, which we think some abusive thing has happened. So how will we tell them? We have to involve the social service in a polite, nicer way.
Yeah. First of all, we'll be having a whole protocol that number one, we cannot let the patient go, especially if it is a child, a minor, an elderly, or a pregnant woman. Okay. So we will tell them, you will be staying here. I'm going to inform my seniors, and we will involve our certain colleagues from social services, and they will get into the details of what's going on, and then we can manage you accordingly. So we are not supposed to scare the patient.
Okay. Won't they cross questions like why you want to involve social service? Like, will they take my chair?
Yeah, I got your point. The good thing in Plab is usually role plays don't cross question. And at this point, they can resist staying there. For example, in a minor's case, that a young girl, she refuses to stay. She says, okay, no, I don't want to stay here. I do want to go back home. And then we can tell her step by step what can happen. Like if it is a medical condition, because of that, you need to stay here. And if you go back home, it can get infected or it can rupture. Okay. Or you can be like we can, at the end, we can say, we can use our authority at the end that we cannot let you go back home unless things are sorted out by security agencies or by social services.
Okay. And madam, there are medical error stations, right?
Yeah.
One question is like, if one of our colleague has done something, we don't know whether he has mistaken or is it something that patient has misunderstood him. Are we supposed to apologize without knowing what exactly has happened, without hearing from our colleague?
Yeah, we will not apologize for the mistake of our colleague without knowing. We will apologize for what has happened. If medical error has happened, if something wrong has happened, we are feeling sorry for that thing. That I am sorry to know that, or I apologize for that has happened to you, or you have to go through a lot. I feel sorry for that.
But we should not judge our colleague, right? Whether
we will not be judgmental for our colleagues, exactly, unless thing is crystal clear. There is some evidence. Then we will not advocate or favor our colleague.
And regarding the medical error, same station, do we have to tell him regarding the incident form without him asking us? Is it mandatory to fill an incident form in every medical error station?
Yeah, in actual practice, they fill incident forms whenever their medical error happens. Now the thing is it medical error or is it patient is not happy with the thing? If it is actual medical error, for example, missing sample, X-ray done without need or anything like this, then it is a medical error and incident form will be filled to sort out things. But if it is just a patient who is not happy with something, then it might not be needed.
Okay, understood. And with the same station, if the patient, patient is not asking us to file a complaint, should we explain him regarding the files in that situation?
Again, this pause, which is usually associated with filing complaint, formal complaints of the patient. There are two opinions, but the actual practice is it is taken as feedback form, not a particular complaint form.
Okay.
So we can offer it even without patient is mentioning.
Oh, okay.
And again, keeping in mind, we can feedback can be positive or negative. So in actual practice, they get the pause, they get the patient offered pause so that they can avoid future problems.
Okay. Like, won't it put us in trouble? Like, if a patient doesn't want to complain, won't the examiner ask why you want to push them, to complain and explain them the facts?
Again, it all depends. If the patient is angry, if the patient wants to give feedback, we are just offering that still, if you are not happy with our management and you feel that you were not treated as you like, you can give your feedback at Paul's. We are not going to ask him that you can file your complaint at Paul's.
But in every stations, medical stations, we have to explain that lines, right, regarding the parts what you have just told.
Yeah. That is why I said there are two opinions. We are not going to push them, but we can tell them that this is your right.
Okay. Understood, ma'am. Thanks a lot.
Pleasure.
I have two questions actually.
Yes.
I've actually joined the session late, so can you please brief the resources for Plab 1 and Plab 2?
There are many resources for Plab 1 and Plab 2, including our med exam experts. You can, first of all, it's better to go to GMC websites, find sample questions.
And Plabable is the one source, right? Plabable?
Might be. For further discussion, to know about these, you can join our Facebook and Telegram groups as well.
Okay. And one more question I have. Like, to get a job there or any kind of training, or do we need to require a great CV of all highlights?
Actually, it depends. If you are not done your internship, in that case, you can join Foundation Year 1. They take international medical graduates after GMC registration for that as well. And you can find it, like after searching, you can find this on GMC website as well.
Okay.
That is Foundation F1 program.
After internship?
Sorry?
We give the exam after internship, like if you want to join the course there over there.
You can appear in the exam after graduation.
Okay.
It's good to do internship in that way. You can start with Foundation Year 2. But if someone hasn't done their internship and got GMC registration, they can do their internship here, which is known as Foundation Year 1.
Okay. Thank you.
Pleasure.
Good evening. I have a question.
Yes, please.
When there is a task where we have to tell diagnosis to the examiner and the management plan, when we finish the history taking part and thanking patient, do we present all the history points to the examiner, or we just have to give him differential or diagnosis only?
No, we will present our case, especially in cases of SIM-man stations. There are certain cases where it is mentioned that at 2-minute bells, talk to the examiner. Then we will present our case, and it usually takes 30 to 40 seconds to present whole case with positive symptoms, what we have done, and what then we'll tell our diagnosis, and then examiner may ask few questions about management, that what do you plan for further, or how will you manage this patient further.
Okay. So the same will go for history taking station as well. Like, we will present the positive findings to the examiner, and we will tell our diagnosis then, and then he will ask about management. Okay.
Yeah, perfect. The same way.
Okay. Thank
you. And in these cases, it is easy because usually in 2 minutes window, when we need to involve patient at every step, it takes more time. When we are talking to examiner, we don't need to simplify things.
Yes,
medical
we don't
jargon.
have to think a lot to tell in simple words. We don't need
to involve the examiner at every step. We will just tell them our plan. Then we don't need to ask them that what do they think about it? Are they comfortable for this? Can they manage it or not? Like this. So it is time saving actually.
Yes. Thank you so much.
You're welcome.
And one more question. You were talking about the division of for history. You said I forgot that. I just remember that you were telling that for management we have to give at least 3 minutes.
Yeah, I emphasize upon your practice time management. That is preferably take 5 minutes for history or data gathering from introduction to examination. And then in rest of the 3 minutes, start with the explaining diagnosis and going to the end of the management.
Okay.
In that way, if in the exam you get something like something is missed, or you feel that you are running short of time, still you will get into the management on time.
Yes, thank you so much.
You're welcome.
Ma'am, I have one more question.
Sure.
In general stations, do we, after the examination part, do we have to, is it wise to explain the patient the professional diagnosis before jumping into investigation? Or we have to first do the investigation, like ask the investigation to the examiner and explain the diagnosis? Which way we have to go around?
In which station will you please elaborate?
Let's say it's a station of stable angina, for example.
Stable angina, okay.
Yeah. After my examination part, do I have to tell the patient, like, after hearing your history and from examining you, I am suspecting a stable angina, but to confirm that we will do an ECG and heart markers, or should I first do the investigation?
Yeah.
After I get the result from the examiner, I will explain that this is stable angina. This is how we're going to manage it. Hope you understood what I'm trying.
Yeah, I got it. The cases of chest, basically leading towards chest infection, where we can hope to get some X-ray finding, or the case where we can hope to get some ECG finding or cardiac markers. In that case, it is advisable to mention investigations along with examination. That, for example, Mr. XYZ, I'm going to examine you with your permission, and I will send your blood, or I'll take your ECG at the same time, the same flow. So when they will hand over you finding of examination, at the same time they will give you findings of initial investigations. But in rest of the cases, sorry.
So it depends upon case to case.
Yeah, it varies. But generally speaking, if we think about chest cases, it's better to mention earlier, because if you mention it later, then again you will consume more of your time in mentioning investigation. Then they will hand it over to you, then you will read it and tell the patient. So when you get both things together with examination, initial investigations, it will be better.
Okay. Ma'am, one more doubt. If we are explaining the professional diagnosis to a patient, then we are asking for the investigation. Let's say we were wrong regarding the professional diagnosis. After we got the result from investigation, it turned out to be something else. Okay. So how will you explain this to the patient? Like,
you mean we have explained the provisional diagnosis to the patient?
Yeah.
And later
already before getting the investigation, already we have explained the provisional diagnosis. But after the examiner gave us the results, investigation results, our diagnosis changed.
Yeah, then we'll honestly accept our mistake, and the provisional means we are not sure, so we will say that it, on the basis of the things you have told me on your examination findings, it seems that you are having this or you're experiencing this. Right? When we get the investigation, but before that we will say, but to be confident about my diagnosis, I need to do this.
Okay.
So when if we get something, we will be, this is the benefit to give provisional diagnosis, that we will be on safer side, that I thought, but it was not like that. And it turns out to be this thing.
Okay.
Instead of that. So we are going to plan in our management this way.
Oh,
things are
we are not going to lose any marks, right, ma'am, for that?
In that case, we are not going to lose any marks. It is the thing,
Okay.
for example, the patient has migraine and we go with subarachnoid hemorrhage, let's say. Then the whole scenario will change. In that case, wrong diagnosis will lead to missing the case.
Okay. Understood. Okay, thanks a lot.
You're welcome.
Thank you very much for this session. I have a question that, firstly, in fact, two questions. First question is related to the previous discussion about the questions when they're asking so many things that first we lead to a provisional diagnosis, then we are asking patient that, oops, it got wrong, and then we are getting investigations and the diagnosis change. Do we have that much in a single station?
Usually it doesn't happen because when we expect to get some results of some condition, we mentioned it earlier. For example, if we are suspecting that patient may have pulmonary embolism or MI, we will mention earlier that we are going to do ECG and we are going to do cardiac markers or that test. And in case when we don't think of anything like this, then we do specialized investigation, and these are usually not provided, like CT scan or MRI.
So what I understood is that when we are performing an examination, after that we are being given the investigations, or this data is given freehand?
No, nothing is provided voluntarily by the examiner or by the patient. When we mention something, in fact, when we talk about examination, the patient will ask, doctor, what will you like to do? What examination? And when we specify that examination, then patient hands over findings to us. Otherwise, they don't.
With them, and they provide us on demand.
Yeah, they provide us on demand. They don't volunteer information generally.
All right. So only we know about a station is just a scenario before entering into the cubicle, and then rest of the investigations and other things that are revealed once we are inside and what we demand.
Yeah.
All right. Thank you. And the second question was about if we are to perform a procedure, and we are then explaining a patient generally that this is the procedure and how we are going about it, consent and everything. After completing all that, do we then explain it to the examiner that first I did this, then I did this, and but it would be just observed and marked, right?
Yeah, they will be observing and they'll be marking. Again, here there are two kinds of opinion. One set of people say that verbalize the things, not every step, but every significant thing, verbalize it, so that if the examiner missed to observe, they can listen to you. But the other mindset is not to verbalize, because when they are sitting there to observe, they will observe and they do their duty. And personally, I go with the second opinion. But there's nothing wrong to verbalize.
Of talking a little bit when you are doing some.
Yeah.
Okay, so what I have understood from this, that when we enter into the cubicle and if we know that we are going to perform something, so we will not be expecting examiner to ask anything from us. And when we are going about some interview, some history taking and management in that kind of situation, we are to tell the examiner what we have gathered from the information and what is our diagnosis.
Usually we are not supposed to talk to the examiner. Okay. And examiner don't respond to us even if we try to talk to them. Our whole interaction is with the patient, except a few cases where it is mentioned outside the cubicle.
Okay.
That at 6-minute bell you will talk to the examiner.
And in that talk also, we will just be explaining what we have done, what is our diagnosis on the basis of history and examination.
Yeah, and what do they ask? We will answer that thing as well.
Okay, do they do ask questions, like they ask about further management, or how if we will be graded if we cannot answer that question?
Yeah, in that case, first of all, you will present your case in 30 to 40 seconds, and then they will discuss about diagnosis if they want, and then they will do what will you do further? What's your plan further? And it's quite simple that if we want to admit our patient or not, if we are going to refer them or not, what medication we are going to give them, and if if there is some mistake, imagine this is 4 marks.
Right.
Management. If you have mentioned 3 things, you missed 2 things, of course you will make the station.
Right. Right. Okay. Thank you
But
very much.
it is important that you hit the bull's eye. You don't miss the vital thing, your most important thing.
Right. Thank you very much.
You're welcome.
Hello, ma'am.
Yeah.
Ma'am, this is Dr. Champak Lal from India.
Yeah. Welcome, Dr. Champak
I
Lal.
have a question. I'm basically a beginner, but I'm very poor in English. So, is it possible that can I give a Plab exam without giving IELTS?
No, I'm sorry. This is the step before giving language test. We cannot apply for Plab 1.
So, ma'am, what should I do? How to improve my English? I'm not good in it.
Yeah, you can go for OET. That is comparatively medicine related occupational English test conducted by Australia. It is comparatively easy as compared to IELTS.
Oh, thank you so much, ma'am. I will consider it. Thank you.
Yeah. And after doing OET, you can book your Plab 1 and then Plab 2, and then you will be working in NHS soon.
Okay, ma'am. Thank you so much.
Pleasure. Any questions? Yes, please, Lal Baksh Sharifi.
Hello, ma'am. Hope you're doing fine. I have just registered myself for Plab 1 exam, and I was wondering that as of now, in how, in which time duration I will complete the Plab 2, and another thing that what else is required for being able to work in the NHS apart from passing Plab 1 and 2, for example, like clinical audits or research studies, are they necessary or obligatory? Thank you.
Yeah. Working for junior doctors, it is the 5 steps. Number 1, making your GMC registration, like reference number, getting your GMC reference number, then doing your language test, Plab 1, Plab 2, then GMC registration. Then you can apply for NHS jobs. Everything you mentioned that can increase the weightage of getting a job, but the basic requirement is this. If you have audit or if you have done some research paper, these things will be adding weightage to your CV. But without these things, one can get job.
Okay. And if I am done with the Plab 1 on the November of 2022, then at which time I'm able to book for a book Plab 2 exam?
It all depends upon yourself. You can assess yourself very well. Usually, at least 8 weeks to prepare yourself for one exam are required. Full-time studies. If working, then you need more time. You can say 6 to 8 weeks, 6 to 8 hours per day for 6 to 8 weeks. Then you will be well prepared, and you can spread it according to your time and space.
Thank you very much. Is Plab 2 sits do they have shortages like Plab 1, or are they more readily available?
It all depends upon COVID situation. However, they have increased the number to double. So now these are more readily available as compared to year 2020 and 2021.
Okay, thank you very much. That's all. Thank you a lot.
My pleasure. Yes, Sana? Dr. Sana raised hand. Can you hear me? Okay, then Dr. Arifur Rahman.
I have a question that when there is a task for examination, like for example, thyroid examination, do we have to start with the relevant like hand examination, pulses and face, eyes, and then thyroid, or just we have to do thyroid first, considering the time in mind, and then discuss to the patient, to the examiner?
Yes, this is like right now, any examination in which we need to interact with the patient, these are being omitted after COVID, like joint examinations, nerves examination, and thyroid as well.
Okay.
But when examination is specified, for example, mannequin, they are doing all these examinations like abdomen, prostate, chest. In those examinations, what is specified, we will do that thing. Secondly, in those in the mannequin, if it is abdominal examination, the mannequin will be of abdomen only. There will be nothing like limbs or eyes. So we can verbalize that ideally I should do these things, but GMC on their feedback from examiners on GMC do's and don'ts, which is available on GMC website, they mention when it is given abdominal examination, please don't waste your time in doing general physical examination.
Okay, I haven't read
suggest
that. I
all
will
candidates
go for
to go for those do's and don'ts. It's just a 6 or 7 pages PDF file, but it will give you a good insight of the exam. There are certain things that GMC itself says that please don't do this. For example, they'd say don't oversimplify the organ's name. For example, don't call a vein a blood vessel or a blood channel.
Okay.
Yeah.
I will definitely read those. Don't answer.
Yeah, I'll suggest all candidates to go for those do's and don'ts by GMC.
Thank you.
Anyone else?
Hello, ma'am.
Yes.
Ma'am, I have another question.
Yeah.
Actually, ma'am, I am a beginner.
Yes.
So, can you tell me how much difficult is this Plab exam? As my friend says that it's a very difficult exam.
At what stage you are?
Now I have to give Plab 1 exam.
You have
I
done
told
your
you
language
before
test.
that I am very weak in English. So first I have to give IELTS and your suggestion OET. But I'm asking about the main exam, that how much difficult is Plab?
When did you do your graduation?
It was in 2016.
All right. In that scenario, you can make it because it is not tricky like post-graduation exams. It is straight exam. However, we need to build our foundation in knowledge. So it is doable exam. In simple words, if I say it is a doable exam with little bit dedication and good resources.
Actually, ma'am, the main issue I'm facing, I'm concerned about my language. Will that be a barrier in the way of my clearing Plab exam?
No. When you clear your language test, it will be quite helpful for improving your language. Secondly, when they test language in language part, then knowledge, clinical knowledge in part 1. And in Plab 2, they assess how do you interact with your patients. Are you respectful, decent towards your patient? Are you non-authoritative and non-judgmental? And are you a safe doctor in terms of practicing medicine or applying medical knowledge?
So, ma'am, the point I'm getting is that if I'm good in my field, then I can clear that exam.
Sure. If you can do medical graduation, you can do anything.
Okay, okay. Actually, one of my friends said to me that I am bad in English, so I can't do Plab.
I believe your English is quite fine. It just needs polishing, and after doing your English test, you will be better able to manage your medical exams.
Okay, 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 ma'am. Thank you so much. Thank you so much, ma'am.
My pleasure. Anything else anybody wants to know? All right. So keep on practicing, keep on studying, and set a realistic goal. And stay in touch. We have Facebook group, Telegram group. You can put your queries there and we'll be happy to answer your queries and address your concerns. Thank you so much for attending today's session.
Hello, ma'am.
Yes. Yes.
Ma'am, I have another question.
Yes.
Do you prepare for Plab exam?
Yes.
Okay. So which individual I have to talk with to? Because I need some guidance regarding it as well.
This is MedExam expert host, as you can see at the top.
Okay, so I have to text her.
Yeah, you can talk to them. Send message.
Okay, okay, ma'am. Thank you.
Yes, Sana. Okay, if there's no more question, we can wind up the session. It was really joyous to talk to all of you. And I'll be happy to help you anytime through our Facebook group, through our Telegram group. You can contact, put your queries there, and we'll be answering those questions. Thank you very much for joining. Have a nice day. Bye-bye.